Okay, so I was trying to be sure that I have all the presenters on this call, and I'm happy to see Dr. Saud on this call, Professor Dr. Buku on this call, and I am waiting for Andrew Teba. He has joined this call. So, colleagues, you're most welcome to this call, and I want to thank you for turning up in such big numbers. So far, we are 72 colleagues who have logged onto this call, and I would like us to get started. But I would like by start giving a preamble to our presentations that we are going to have from our three key presenters in here today. One key thing is to let everyone know that we still have Empox in the country, and it is being detected amongst populations across the country. And the presentations of the disease are having a shift on how they are patients are presenting these days. And because of this, there are very many factors that are leading to additional knowledge, clinical decision making that needs to be made. And also, there's prolonged stay by these patients in the hospital beyond the required period of time. It was clear that within 14 days, someone should have gotten healed and even dealt with the lesions on their bodies. But we have realized with time, as the patients are being managed and the disease drift in terms of its presentations in different high risk and vulnerable populations, the disease has gained its presence, and also we are having other co-infections that are presenting as a result of long stay, and also the exposure of a systemic system to the external environment that could be engaged with or presenting with some of the bacteria, including viral infections that also can be gotten within these facilities that we are operating in. There have been also nosocomial infections that have been identified in these patients, and this has affected their delay in terms of getting better or when treatment is given for them to improve. And one key thing that has come through is seeing these site infections that are presenting, more so the skin infections that have been presenting in these patients. And there was need that was generated. There was need that came through to ensure that we could know what could be the cause of these presentations. And a group of scientists came together and felt there was need to attend to these patients beyond only doing the virus get better. So with that, there were some results that came through, and we identified some bacteria, and some have been like alert or escape pathogens, if you know some of these ones, that really present with some resistance mechanisms. And because of that, we felt there is need for us to create an awareness. And the reason why these experts are seated here is to help and support us appreciate the knowledge that we need to share, and also the experiences we have gotten in managing these patients, basically at the Entebbe isolation unit, or even they could present at your facilities as you are managing these cases. So because of that, I would let me introduce a few colleagues. We have had bacteria like E. coli, Pseudomonas, Klebsiella. These have all been presenting with very multi-drug resistant patterns of the resistance profile, and this creates a worry and a drift in management of these cases. So because of this, we have engaged the National Health Laboratory Department, working closely with the Uganda Virus Institute, as well as the regional referral hospitals, to ensure that we can manage these cases in real time to support their well-being and also recovery process to be shortened in one way or the other. So with this all said, I would want you to allow me go through this to introduce the panel of people who are here, and I will start straight away with Andrew Teba. He's a laboratory scientist with an infectious disease background. He's a certified assessor. He's a subject matter expert with the Africa CDC as well as WHO in one in wastewater-based surveillance that we currently do in the country. And also in terms of risk management, he has been an expert supporting a number of countries, and he has done great work in these countries. And he is the laboratory manager for the Central Emergency Response and Surveillance Lab that is at Wandegia. That has been one of the labs that has been leading the reference testing for Empox, including arboviruses and also Ebola that was recently detected, and his lab was among the first labs to confirm the Ebola case we did have in the country. So Andrew, you're most welcome to this call. Andrew, are you well? Okay.
Yes, thank you so much, Morgan. I'm humbled to be here.
Okay. Next, we have Dr. Sauda Namubiru. She's a clinical microbiologist with a medicine background. Background is in medicine. She's one of the champions of diagnostic stewardship in the country, and she's an advocate for microbiology and AMR utilization at regional, referral, national level, and also ensuring data quality in line with AMR. She's an epidemiologist with a very strong background, and this has been done through the National Institute of Public Health, and she was one of the fellows that was there I think 2 years back, and she has been a very prominent person in linking up epidemiological data with lab-based data to inform clinical decision making. So Dr. Sauda, you're welcome to this call.
Oh, thank you so much, Morgan. I'm more than humbled to be here.
Yes. And lastly, allow me to introduce also Dr. Ebuku. Dr. Ebuku, I want to introduce him in very many aspects, if you allow me, colleagues. And we are very humbled to have him here, first of all, as a doctor, to be part of our presentation, and he's humbled to join us. Dr. Bekwaro Obuku, I would want to introduce him in these avenues. One, he's the former president of the Uganda Medical Association. He's a very strong activist when it comes to relating research and science. And I'd also want to inform colleagues on this call, he's one person that has held strong the medical background in ensuring that we can have policy aligned to our structures of our health systems. Dr. Buku still, as I speak about him, he is also, I would say he's also coming in the next elections as a member of parliament for Oyam South. And he is also, he has just finished his doctorate. He's actually having a PhD as we speak on this call. And he has been one of the strong activists ensuring that we can implement global security and also ensure that we can strengthen systems through research and policy. So Dr. Buku, we are happy and glad to have you here. He's one of the persons actually who also fought for salary increment within the medical association. So having such people on our calls also gives us more added value and addition on this call. So Dr. Buku, you're welcome. If there are any other introductions that I could have missed out, please feel free to air them out.
Thank you very much, Morgan. I'm a medical doctor, a medical officer actually, and I used to work with the IDI in the global security, and that's my little expertise there. Other than very delighted to stand before distinguished laboratory people, professionals, to say one meeting.
Okay, thank you. And he's a very humble man. You can hear from his speech. So, not to waste any more time, we want to make sure this presentation is very explicit and simple for all of us to appreciate and understand. We want to make the science very simple for all colleagues on this call. And at all this, we want to ensure that knowledge must be really translated from one person to another or from one level to the other. And we want to ensure that this academic community really inspires us to be strong stewards of laboratory work. I want to say everyone in your different places of work, in whatever you have been doing, we are very appreciative at national level for ensuring that we combat and manage Empox. Lastly, you will allow me to give Dr. Killian just 1 minute to introduce himself. I do this because he's one of the persons who has really been there strong in advocating quality management systems. If you know one of the entities through A Global, he was one of the stewards that has raised up a number of us who are here. And I would like to give an opportunity to just say hello to us as we get started.
Morgan, I hope you can hear me.
Yes, please.
Thank you so much. It's always a pleasure to join, and I don't think there is anything particular that I bring added to this. I am just so delighted to be part of this discussion. The whole story of Empox is really key, and the whole AMR addition to it is very vital, and I think this is a much needed discussion, and I'm glad to be part of it, and I encourage everybody to please stay the length of the discussion, and let's discuss what we can do and strengthen our systems. Thank you much indeed. Have a wonderful afternoon, everyone. Over.
Thank you. And I'm glad these are some of the things that I really love seeing when we have people of such stature, professors, and willing to listen and learn more. And these are the avenues that I request everyone to always have to ensure that we grow in our knowledge space to ensure that we achieve these gains. So I want to thank all the regional referral hospitals, the districts, the health facility staff, the national level teams, for the great work we have done. I can't say it so much for everyone and make everyone speak, but I want to thank you all, and I believe when the commissioner joins the call, she'll do the same, and thank everyone for the great works we have done. We look forward to increasing our capacities in everything we do to ensure that we are as good as we have been in the previous engagements, more so in the outbreak space. Lab has been very pivotal, and it has provided a very good insight and direction in management of these cases in Uganda, even through sequencing and also the change in disease presentations as opposed to the typical presentation of Empox previously. So at this point in time, you're going to allow me, allow Andrew join in, and he makes his presentation and share his screen. Andrew, feel free to introduce yourself again as you get started. Then we shall have discussions that will be coming through at the tail end of all these three presentations. So Andrew, you're most welcome.
Yes, thank you so much, Morgan. I think you introduced me very clearly. Andrew Sauteba is my name. Just as Morgan stated, I manage the Central Emergency Response and Surveillance Lab, a public health lab under the Department of Lab Services, charge of handling epidemic-prone pathogens. And we've been key when it comes to Empox testing, having confirmed over 6,000 cases out of the national cases, but obviously following closely with the events. Morgan, allow me dive into the presentation, if it's well for me to continue.
Sure.
So team, just as Morgan has stated, the purpose of this webinar is to look at extended testing for clinical care. And my confidence is that at the end, we'll be in position to know, to share knowledge and clinical reasoning around when, how, and why extended testing for Empox confirmed cases is very pivotal, especially when it comes to improving patient outcomes, minimizing the transmission, but also optimizing the use of diagnostics. And by the end of the sessions, we expect us to be able to explain the indication and algorithm for the extended testing, the methods and sites for the testing, and also the other key aspects, including the lists of the tests that are very pivotal with regards to extended testing. Our team, just as we'll appreciate extended testing, here we are looking at those key diagnostic investigations beyond the initial confirmation of Empox, which is usually through the skin lesions, going beyond, and the focus is on the supportive laboratory evaluations. And just as we'll appreciate to help us monitor the viral clearance, but also identify complications and detect co-infections. But also something very key is to guide clinical decision making. And we'll look at the point of care tests and also the additional laboratory tests, plus also the extended screening by the clinicians. The beauty is that we have Dr. Buku on the call, but also with plus other clinicians. But also something very important is to ensure that there is improved diagnostic accuracy, aspects of risk stratification, and also personalized treatment plan. And overall, our desire is to see that we support in decision making. Extended testing is really critical when it comes to us assessing disease severity. A team accurate assessment of disease severity is essential for us to be in position to determine appropriate level of clinical care when it comes to whether the patients will be outpatient or inpatient, and also other key aspects that we are going to look at in the upcoming slides. But on disease severity, I know our Uganda guidelines for management of Empox patients, the May 2025 guidelines, help us to stratify disease severity with those that are mild, with 25 lesions, below 25 lesions, and then the moderate 25 to 99, and severe 100 to 250, and above 250 with grave disease. However, something key to note is that Empox severity is clinically heterogeneous, and we can't only rely on the lesion counts and also other key aspects, including the presence of lesions in other body parts and the confluence of these lesions. So something very critical is that beyond the stratification as per the guidelines on the number of lesions and the confluency, and also the presence on different parts, the laboratory becomes very important to help us identify other key factors, such as the immunological markers, the CRP, and also other key aspects that can help us to guide on whether the disease is mild, moderate, or severe. For example, if I leave this slide, you realize that if an individual has probably HIV and with a low CD4 count, you realize that such a case, even though, for example, CD4 count below 200, and maybe with cancer or sepsis or encephalitis, even though the lesion counts are less than 25, which could be stratified as mild, because of the lab findings, such stratification has to change to an individual having either severe or grave Empox, and that's where lab becomes really very important. Secondly, the extended tests that we are going to look at are very key to help us identify co-infections in Empox clinical care, and this is very important because Empox rarely occurs in isolation in outbreak context. When you look at DRC and other countries, and especially a country like Uganda, where we have a number of outbreaks and even diseases. So you realize that co-infections such as HIV, the STIs are common. For example, the STIs, you realize that Empox and STIs share the same transmission route, skin to skin, sexual fluids, the mucosal contact, and also some of the symptoms overlap those of STIs, such as the ulcers and the discharges. And at times, even when people have Empox, they can have some of these co-infections for the STIs. And if there is co-infection of STIs, for example, there is an increase in local inflammation in some of those areas. And if these are not identified early on time, there are a lot of chances when it comes to worsening of disease severity or alteration of clinical presentation or delay of healing. And at times, some of these patients will have the discussions, and the doctors on the call will be in position to share with us such. So identification of, for example, the STIs early, especially in confirmed patients, is something very key. The bacterial super infections, those ones we'll speak about them in depth when it comes to the microbiology. But something very key, realize that Mpox damages the skin and creates a port of entry of bacterial pathogens, and that leads to increased the susceptibility for sepsis, abscess, and necrotizing of the soft tissues. So the earlier we detect this is something very important. When it comes to varicella zoster or the chicken pox, even though we emphasize that diffuse the monomorphic vesicles without the lymphadenopathy, it's one of the ways that can help us to distinguish whether someone has varicella zoster or Mpox. But at times there is still confusion, and there are patients that can have both chicken pox and Mpox. So the ability for us to distinguish, not distinguish, but identify some of these co-infections, it really strongly helps in management of the Mpox patients. Something very crucial also is with regards to the monitoring of organ functions in the confirmed cases. And this is very important because even though Mpox is primarily known as a dermatotropic virus affecting the skin, evidence from some countries, when you read around, like Nigeria, DRC, shows that some populations can have disseminated Mpox. It can disseminate systematically and cause mild organ function and also trigger inflammatory and metabolic complications. And also it can exacerbate some of the comorbidities such as diabetes. So it's something very important to be in position to identify, monitor the organs, and through a number of tests that we are going to appreciate, the liver function tests, probably looking at the liver, because at times the elevated transaminase may suggest whether there is viral hepatitis syndrome, and also the renal functional test, the creatinine, the electrolytes. All of those can help us to be in position to look at the function of some of the organs, and also track whether there is dissemination, systemic dissemination of the Mpox, including the bone marrow, just as you can observe, the CBCs and the anemia. If we don't identify such early, we can have complications of our patients. And also the brain, the neurological function is something very important. And some of these help us to be in position to identify the state of the patients and be in position to manage them better. Something very key also on extended testing is informing the use of the antiretrovirals or the supportive care. Antiretrovirals, even though our national guidelines do not strongly, I need to say routinely, in fact the statement is routinely, recommend use of antiretrovirals such as the Tecovirimat and other antiretroviral drugs. Sorry, Tim. Other antiretroviral drugs. It is something very important to note that in severe instances, WHO but also our 2025 guidelines may
the president to have a word or two. I know we have gone past the top of the hour. And then Eric, I think I'll give room to you to invite Dr. Susan Nabada to give her parting remarks. Thank you. Eric.
Yeah. Yes, thank you so much, Morgan, and all the presenters, Dr. Ikwaro Buku, my brother, colleagues. He's contesting for Member of Parliament for
sent.
I'm not meeting.
Infection, just as we indicated, can lead to death. Disabling and lead to poor prognosis. But without us doing the electrolytes, the CRP, the cultures, we are not in position to be in position to detect such early. So, team, there is a quiz here that I'll request you to respond. Of our patients, and also the brain, the neurological function is something very important. And some of these help us to be in position to identify the state of the patients and be in position to manage them better. Something very key also on extended testing is informing the use of the antiretrovirals or the supportive care. Antiretrovirals, even though our national guidelines do not strongly, I need to say routinely, in fact, the statement is routinely, recommend use of antiretrovirals such as the Deteco very much and other antiretroviral drugs. Other antiretroviral drugs, it is something very important to note that in severe instances, WHO, but also our 2025 guidelines, May 25 guidelines on patient care management for Empox, emphasize monitoring of before administration of the antiretroviral drugs for us to be in position to be guided by the lab. And this is something very important, especially amongst those that have severe or the high-risk patients, those with early complications, and also issues to do with organ vulnerabilities. And we will be in position to identify, especially when it comes to patient severity, just as I indicated, the patient severity matrix can only easily be gotten if we have been able to run some of the tests, and also identifying those that are risk, the patients that are at risk. For example, people living with HIV, with low CD4 counts, the pregnant women, you will need to do the HCG, you need to do the HIV panel for you to be in position to identify some of the risk groups of the patients. And also those that have complications. You can't be in position to identify complications explicitly without doing some of the tests like the CRP, the wound cultures, the electrolytes, the urea, creatinine. So for us to be in position to utilize the antiretroviral drugs as per guidance of WHO on monitored emergency use of unregistered investigations, investigational interventions, the antiretrovirals, because they are not actually approved to be used for Mpox. We need the lab to be in position to help us guide on the administration. Something very key also why we need extended testing is to be in position to detect risks early that are associated with prognosis and complications, and this will helps the clinicians to be in position to stratify the patient's individual vulnerability. You realize that Mpox severity is not uniform. We'll hear from the clinicians, but this is one of the experience that some of us have been able to monitor. So vulnerability depends on a number of factors. Obviously, the host factors from patient to patient, including the vulnerability, some of the factors such as pregnancy, and other comorbidities. So HIV panel, the HCGs, the diabetes screening, and the nutritional markers, the albumin and the BMIs, you realize that the lab becomes very pivotal. The other key aspect is on disease progression within the body. You realize that Mpox can evolve from the localized skin lesions to the systemic disease, just as I indicated earlier, evolving the liver, the lungs, the central nervous system. And we realize that for us to be in position to monitor that, we need the renal functional test, the liver functional test, the CBCs, the CRP. They are really very important. Lastly, is on the potential for adverse outcomes. You realize that complications such as encephalitis, the sepsis, or the electrolyte imbalance can be fatal or disabling and lead to poor prognosis. But without us doing the electrolytes, the CRP, the cultures, we are not in position to detect such early. So, team, there is a quiz here that I'll request you to respond in the chat box. Why extended testing? Why do you think extended testing is very important? I now hinted on this, but in the chat box, you should be in position to respond. Allow me proceed to the indication algorithm for extended testing. You realize that the extended testing that we are speaking of is not a one-size-fits-all. It has to be aligned or guided by the clinical presentations and also the severity indications, the risk of complications, but also the baseline organ function. And that's why the algorithm is very important. We are not going to be in position to subject all the patients apart from the HIV and syphilis, just as you can observe. The 2025 May guidelines for patient management require us to do both HIV and syphilis testing for all the confirmed cases due to the co-infection rates that were presented in the severity 2024-2025 severity assessment by UNIPH, where they found out that close to 30% of the 244 cases had comorbidities of HIV, and also a number of those had syphilis. So, however, for the rest of the tests, they have to be the cultures, the cultures to help us detect bacteremia, sepsis, and obviously bacterial superinfection, just as we indicated, can lead to death. Also, the wound swabs, and these are very important because that guides the antibiotic therapy, which is obviously very key because many cases have inflamed lesions or the pleurent or the inflamed or pleurent lesions. Also, something very key are the CBC and urinalysis, which is normally done as a baseline infection status, and it's normally done on admission, but obviously repeated if there is worsening to help us detect the renal stress and also the other complications such as the cytopenias. Also, something very important is the CRP, which is an inflammatory marker, just as some of us might be aware, and this helps us to monitor if there is systemic inflammation, especially where systemic inflammation is suspected. And obviously, high CRP is normally linked to complications such as sepsis. The renal liver functional tests, the electrolytes, obviously these that look at the organ function, and if there is, they are very important to help us, especially when patients are to be administered the antiretrovirals, and also they help us to detect any organ compromise. The number of obviously platforms, point of care, and also central testing, the HIV, syphilis, the TB LAM, just as we go through them, this should be done at the point of care, but also the central labs continue to support us with the with the monitoring of the viral loads of Empox, the culture, and other tests that might not be present at the points of care. Let me begin with HIV testing. Just as I indicated, the severity assessment that was done by UNIPH indicated that close to 30% of the patients that were by then, the 244, had both HIV and Empox. And also something very important is that people living with HIV with CD4s less than 200 cells per microliter are normally at a high risk of severe disease and also prolonged shedding and ultimate death. So it is something very critical to note that our national guidelines require us to ensure that all patients mandatorily are tested for HIV upon admission. That is something very important. 2, syphilis. Just as I've indicated, the severity assessment indicated 30% of these having comorbidities of HIV and also syphilis. And also something very important is that the route of Mpox transmission and that the route for some of these STIs is the same. So syphilis testing is very key and it's mandatory. And especially when you note most of our patients have anogenital ulcers and also some of those mucosal lesions. And these features overlap with secondary syphilis, and that's why it's really very important to be in position to do the syphilis test to prevent associated complications, just as you observe, including blindness, the heart and blood vessel damage, and all these. And key to note is that we as a country use the rapid immunochromatographic assay to detect the Treponema pallidum antibodies, and obviously they are field adaptable, so they should be in position to be used at the point of care, and also very key to help us to triage and do early treatment. And they are sensitive and to be in position to be used to help us to prevent those complications, just as you can observe there, including paralysis. TB screening among severe cases is non-negotiable when it comes to a country like Uganda, which is among the 30 TB high-burden countries globally, TB HIV high-burden countries. I was just looking at the literature that where 2024, we registered over 50,000 new TB cases as a country, and these Mpox patients that we are admitting, they are from within the country. So it's something very important to note that patients with advanced HIV, those ones with CD4 less than 200, are normally at a high risk of TB co-infection, and which might present atypically, because they might not have the cough, but can present atypically. And the tuberculosis in urine can be identified. We have the TB LAM kits available, especially amongst those that have HIV. In fact, not especially, specifically among those that have HIV. And just as I indicated, such helps to quickly do a bedside treatment, confirmation, detect active TB early, and also be in position to help us to activate treatment as soon as possible. The serum cryptococcal antigen screening is something very essential, and this is prioritized in our HIV testing guidelines, especially amongst those with advanced immunocompromisation, those with advanced HIV with CD4s less than 100. And Mpox patients with HIV at times present atypically, and if diagnosed with cryptococcal meningitis, it can lead to adverse effects or challenges, especially when it comes to morbidity. So it's something very important to screen for the disease, for cryptococcal disease, and amongst the Mpox, and especially those that have HIV, and obviously those that are tested positive, we expect to ensure that they are treated Key to note, we have the CRAG test, serum CRAG tests available for the lateral flow immunochromatographic assays, and these ones are key to help us pick up the infection. Obviously, when a visual band is formed on the strip, the way we do our RDTs, we expect to activate treatment. Something very key also is with malaria. Malaria, we're a country which is endemic with malaria, and we remain one of the highest burden countries with malaria, with over, should be close to 10 million cases annually. And obviously our patients are not exempted. So it's very important to differentiate any fever, because in fact, in the severity assessment that was done last year, it was noted that close to 83% of all the confirmed cases, the 244 cases, they presented with fever. And obviously fever, it's very important to be in position to identify the co-infection of malaria and Mpox. Even though they present similarly with the fatigue, the same feverish signs and symptoms, very important to identify those that have the disease and be in position to give them additional treatment. And obviously, something very key to note is that we have capacity to do the blood smears and also the RDTs within our facilities. Something very critical is on other supportive tests, such as the liver functional tests amongst the Mpox confirmed cases. And these are recommended especially for those that have the systemic symptoms, just as I hinted on earlier, and those that are to be activated on antiretroviral therapy, given that especially the ALT and AST, and these are common, especially with those that have the severe Mpox disease. So something very important is that the LFTs will help us to monitor the liver involvement of the injury or the dissemination of Mpox to the liver, but also to help us guide on the antiretroviral therapy. Especially WHO is critical on the admission of the antiretroviral drugs, that these have to be given, especially the Pseudomonas is hepatotoxic. One of the antiretroviral drugs, I'll have to double check it, but should be Pseudomonas, which can be given to the Mpox patients, or the tecovirimat, some of those drugs. It's something very important to note that these antiretrovirals have hepatotoxic effects, and close monitoring of the ALT, the AST is something very important, plus bilirubin amongst the patients that are to be given this antiretroviral therapy. The renal functional tests are very critical, and they are recommended as for extended testing, the electrolytes, and something very key for those that have the severe disease, those that are vomiting with diarrhea, the dehydration, and also those that are to be given the antiretroviral therapy. WHO requires us to be in position to monitor the renal, to do the renal functional tests, to look at those electrolyte imbalances, and something very critical is that it can even worsen amongst those that have HIV, the children, or those that have sepsis. So it's something very important to ensure that we assess for the kidney function, and also where we are doing, where we are administering the fluids for fluid management. Also, in addition to the renal functional tests, it's urinalysis. Urinalysis is recommended for those that have moderate and severe disease, to also confirm whether they are, especially those that have systemic symptoms or where we suspect mucosal involvement, and those that have symptoms of dehydration, to help us monitor for any possibility of kidney damage, the UTIs, and also the metabolic disturbances, the ketonuria and the rest of those calorimetric measures that can be monitored with the urine dipstick. So obviously, the implication of this is the clinical utility note implication is to help us to ensure that there is rapid bedside screening, and also to guide on whether to detect any renal involvement, and also to guide on antibiotic therapy, especially where we suspect to have UTIs. And another key aspect are the inflammatory markers and also blood glucose. You realize that the inflammatory markers such as CRP, they are really very important to track, to help us be in position to confirm any inflammation or tissue damage, and to assess the disease severity, monitor treatment, and amongst the Empox patients. And something very critical is that especially those that have the severe disease, and also those that have moderate disease, to be in position to help us track whether there is systemic dissemination, or those systemic dissemination, and those that have the systemic symptoms, and with a very high score of the Empox severity assessment. So the latex agglutination test can help us to be in position to do the CRP, and also the anti-CRP antibodies using the turbidometric methods can help us to monitor, not to monitor, but to detect, to help us to measure, to do the CRP testing at the low level at our facilities. Something very critical also are the CBCs, the blood sugars. To note is that just as I indicated earlier, there can be possibilities of the Empox induced, the stress induced hyperglycemia, and this can be monitored, detected, especially the patients that have acute infection such as Empox. Something very critical to note is that acute infections such as Empox can trigger stress and a stress response. And we know that stress response leads to cortisol or other catecholamines being released, and these ones can lead to insulin resistance, and also can lead to elevation of the blood glucose, even in patients that do not have diabetes. And where there is insulin resistance or elevated blood glucose, wound healing becomes complicated, and also you'll have an increase of secondary infections and obviously higher mortality. So it's very important for us to know that random blood sugar monitoring is something very key when it comes to monitoring of patients that have Empox. Something very important, and Dr. Sauda will emphasize it in depth in the next slides, it's on culture and sensitivity. You realize that Empox lesions are prone to secondary bacterial infection because of its disruption of the skin barrier, creating those, the entry points for bacterial colonization. And the Empox severity scoring system looks at that, our national one. And for us to be in position to confirm presence of bacterial colonization, the Staphylococcus aureus, the strep, the Pseudomonas, we can't do that without culture. And also to be in position to confirm the best treatment regimen, we have to be in position to do the antibiotic susceptibility testing, to be in position to target therapy when it comes to our patients. So as something very critical is that for those that are suspected of bacterial colonization and obviously, which can lead to sepsis, it's very important to be in position to do culture and sensitivity amongst our patients. Lastly, amongst the extended tests is the CBC. And this is very important because it helps us to give a snapshot of the host immune response, the leukocytosis, the leukopenia, the neutrophil, the neutrophil lymphocyte ratios. All those are very key markers when it comes to systemic inflammation or poor prognosis. So the CBCs are very important to help us track, to know whether we're on track, to identify early, especially amongst patients with the pleural lesions, with fevers, those that have, where you see really the mucosal involvement, to be in position to manage them better and also track prognosis of them a little bit better. So the assessing of the systemic response, even the secondary bacterial infections, and also other underlying infections, but also even to be in position to track other hematologic complications and comorbidities like anemia, like anemia obviously is the most common hematological complication, and also monitoring the disease progress, just as I indicated, where you realize that the resolution of the lesions is a little bit slow. So it's really very important, and the number of platforms, the flow cytometric, the colorimetric method for the HB concentration, the electrical dependence using the cell counts and size, they are really very important to help us give a snapshot of the patient status, to be in position to fast track the resolution of the inflammation and also the recovery process. So team, you allow me skip this and quickly get to this last slide that emphasizes the test, the sample type. Something very important is that we need to appreciate that the principles of proper sample collection to be in position to do these tests still are very critical, as per ISO 20658, which emphasizes sample management from the patient identification to ensure that the container which is used is suitable beyond it being sterile, leak-proof, but also it has to be compatible. And just as you realize, if it's HIV testing, it has to be an EDTA tube, a syphilis, the plain, and all. I'll not go through all these different tubes, the EDTAs for CBCs, the RFTs, but something very important to emphasize that we have to ensure that garbage in, garbage out. So a right sample has to be collected so that we are in position to get the actual results. But something very critical is that obviously if it's HIV, the purpose is to detect whether this person is HIV positive or negative. And so those are the expected results and the implications, the interpretation. Obviously, for those that have HIV, it means that they are at high risk and they have to be managed better. I think I've been able to go through all these implications. I really don't want to get back to each of these. Morgan, I think that's the end of my presentation, but something very key, just as I started off, I indicated that extended testing is very crucial, and it should be integral when it comes to comprehensive management of our patients, to be in position to manage them better, and also to be in position to improve on prognosis. Morgan, allow me get back to you and allow Dr. Sauda to push on with the next slides of the presentation.
Thank you, Andrew. Thank you so much for being so detailed in your presentation. I think one key thing that Andrew brings out for us to appreciate here is that the lab is not only providing detection or timely detection or confirmation for these public health concerns, but we are getting into the space of having additional value added to our tests. And this is basically through having extended tests that should be done. And I would like to inform you colleagues that Andrew's lab has been one of the first labs that has been set up to provide the complementary testing more so to treatment units for any public health event that could happen in the country. That is in Kampala, but we know that as we set up these systems in all these places, wherever we shall have treatment units or those holding units, they would be so supportive in terms of setting up these functions of the laboratory. One key thing to put forward to us to understand is that we need to enhance and improve patient care, and the lab is providing this through extended testing. And the other bit that has also come through is that we're using existing systems that are in place in new facilities to enhance patient management by case management. So case management has also introduced a new guideline that is in place to support and guide on what should be done. Now, because of this, we have also made sure we integrate our presentation. And before Dr. Sauda comes, we shall be having Dr. Buku to join the call and create that synergy to appreciate what Andrew has just been saying in relation to management of these cases. So with that, you will allow me, Dr. Sauda, you'll hold on, have Dr. Buku come in to make his presentation. For us, the laboratory on this call, I know you have also doctors on this call, but is to create that synergy and to appreciate the linkage of how work should be done. And I'm happy to see, Andrew, you're being appreciated for the good presentation you have made, and we are glad to see that. I take note of some colleagues who are on the call here. I think I'll give some preamble to them at the later point of the presentation before we get to the discussions. Allow me get to Dr. Buku's presentation right now so that we can look at that linkage that Andrew has been speaking about and how we can relate this in terms of managing the cases. So I'll be doing this to share so that we can have Dr. Buku's presentation come through. And Dr. Buku, I want to hand over the mic to you so that we can get started with your presentation. Feel free to get this started.
Thank you very much for inviting me yet again here. I'm using those slides celebrating 100 years of Makerere because I'm part of Makerere as well. We have something called the Center for Systematic Use and Knowledge Translation, where we do policy-related work. I wouldn't say I'm adding on to Andrew's presentation, Keba. I'm very delighted, Keba, working with you and Dr. Tita and Dr. Eilu, as well as, a number of you in your work. I call it a commercial break just to sort of give it perspective. I'm also learning a lot, and I'd like to learn from Dr. Sauda's, very, very technical presentation that will come. I'll listen through. So I'll make it very brief. Would you please take me to slide can you remove this and take me to the pre-presentation? No. Just pre-presentation so that I look at the slide. You can just escape. You can escape, then we look at the slides. Yeah, go down a bit. Go down. Go down. Go down, go down, go down, go down. I think this is the most important. Go down. Go down, go down, go down. There, that one. No, the one up. That one. Yeah, the one below the graph. No, the next one. Yes. So I happen to sit in the Health Policy Advisory Committee of the Ministry of Health, and this is where I interact. I interact with some of these important things. I wanted to say one important thing. Can you take the slide down? Next slide? Yes. This is it. This is the most important part. You must always understand yourselves in the position of the health system that as laboratory professionals, could be technologists, technicians, even professionals, you keep the doctors and nurses from killing you. And as we move more and more into advanced medical practice, if you're in Canada, for instance, if you're in the USA, you will understand the burden of actually conducting these investigations and the importance prior to making decisions with even legal implications. I thought this is the most important message, that at times we have to give it perspective as we pursue these tests. I can go to the first slide now. So I must acknowledge that I got the first slide. I got this work from colleagues. Next slide. And I wanted to acknowledge them. Dr. Mwanga Michael, who is the Assistant Commissioner Health Services Surveillance, Dr. Ronnie Bahatongire, the Acting Commissioner Health Services Clinical Services, and then from UNRO, an immunologist, Dr. Eki Andrew. I have no conflict of interest in my work with the Medical Association, the National Drug Authority, or the University of London, where I provide submissions. The next perspective is the next slide. I used to work with the next slide, please. I used to work with the National Action Plan for Health Security team, the NAPS side. And even from humans, they are increasing. And that's really the problem we must pay attention to. This problem. Next slide. And therefore, last month I was so delighted to have been part of a team that had this discussion around occupational health and safety. So, we can be very interested in fighting these bugs, but ultimately we needed to first make sure we are also alive. We've heard of also healthcare professionals who are now getting Empox in other ways, and you must really be very interested. So a message I keep passing around is this one around what is available to you on the left, which you should be aware about. Your supervisor should tell you about it, is the workers' compensation. There's a law, by the way, around illness, injury, and death, where you should be provided treatment support, and compensation in the event of injury, and the amounts are usually 60 times the 60 times your salary. And the line ministry, health and gender, usually had an exchange of, we just can't be able to do this. But recently there was a court ruling which was a success, the death of one doctor during the COVID pandemic, and court awarded costs. I'm saying this because I was very fortunate to sit in the National Task Force for the first time after so many years of not doing clinical practice. And two things struck my mind. Nobody thinks about the frontline medical professional, be it the lab, be it we enter these offices, these big organizations, usually three-letter words, CDC, WHO, and so on. But, you procure a machine which is $300,000. And that can just be the allowance needed to motivate, 100, or 1,000 workers. So we need to think about workers anywhere, in the back end like the lab or the front end, as a key resource in advancing this. Even in the pandemic treaty was going in WHO, and it was ignorant of this reality. And therefore we have to emphasize that, please, let's have a reality check. If you look at, sorry, there's an interruption there. Can you hear me now? Morgan, can you hear me?
Yes, please.
Yes, you can hear you.
Yes. So on the top right is a doctor.
We can hear you, doctor.
Doctor who was the first victim of the Ebola outbreak. And this guy was in the surgery. He's a surgeon. So whoever thought Ebola would catch a surgeon? Because we are always thinking it's in the outpatient, out there. And here is a surgeon who passed away, the Tanzanian surgeon. On the right were so many, including laboratory professionals, who passed away from, Ebola and other illnesses. Down on the right is the estimation we were trying to do. We were trying to convince Ministry of Health and Gender to come up with really a clear plan, and that when you're talking about occupational safety and health, every person who enters the health workforce should be introduced to this, and every manager, so that we make the system work, because it's within the law. And we say this because we are aware that, businessmen who made losses during COVID-19, some who made losses in the Sudan war, are actually organized and they compensate themselves. It's a slide I didn't want to show in the interest of time, but it's there. Next slide. So that's a very important message. The other one is this situation report, which many of you have seen. Really, the cumulative cases are about 7,000, the deaths are about 50, and new confirmed cases and so on are all there. And there are 66 active districts, of which 119. There are 190, about 120. Which have been affected out of the 146, including, of course, municipalities and cities, compared to the 66 who are actually active by the end of last month. So these are slides, of course, I got from the HPAC presentation. Next slide. Just to give a perspective, there is a preponderance towards the males. Maybe it could be that they have more multiple sexual partners. I don't know. But, the more males are affected, slightly more. Next slide. The other fact is that it has it behaves like HIV. I did most of my clinical work in the early 2000s, prescribing Trionion and Truvada, and, in Arua, and then here at Uganda Business Coalition, and then MJAP and IDI before 2007. And, the distribution of Empox is really like HIV. They work, so that age structure is similar to HIV. For instance, next slide. And, it's an urban disease, as you can see, really affecting Kampala. The population dynamics there are such that, the transmission of Mpox, like any other, even Ebola, is promoted. Next slide. The other important message is that it has been noted to be the preponderance to move towards HIV, but the association is strong on death. The association on HIV and death in Mpox is very strong. Next slide. I will not go into so much of clinical care. One, because I don't think I'm actually qualified. I'm not the best person to say this. Two, because I think Dr. Keba did a very good job, and Dr. Sauda will augment that. But the framework is one, as usual, because you may be the only doctor there as a laboratory professional. You try to recognize the disease through, of course, signs and symptoms, isn't it? But as you can see in the first panel there, adequate PPE is very important when you suspect this. This I must emphasize, because I know it is not emphasized as much. Many times, as medics, we concentrate on knowledge, saving lives, and we forget ourselves. I will tell you, when we were at the World Medical Association in Chicago, in I think 2018, we amended the declaration of Geneva, which was Declaration of Helsinki, that I shall consider my welfare, and you must be okay. You as a medical professional, whether in the laboratory, whether a nurse, or for the patient to be okay. So I wanted to emphasize those things that are rarely emphasized. The second one, of course, is to assess using a structured approach. There are tools given for patient disease, identification and diagnosis. Then the initial care, as you know, there is no treatment, but there is vaccination. We shall talk about it down, and then refer when it becomes complicated. I want to say a few things. I want to echo the message of the PS in the last Health Policy Advisory Committee we had. One is that now Mpox is everywhere, is omnipresent. So the idea of calling for transport to send to Entebbe is done and dusted. You manage it where it is, because it's now widely disseminated. Just like COVID, initially you catch someone, you send it to an isolation unit. But at one time it had spread into the community, so you needed to manage it where it was, except if it's complicated. Next slide. And they need ICU. The clinical features, whether these are important to you or not, it's, the maximum incubation would be up to 21 days, typically between 6 and 13, 2 weeks. And then there are these phases, okay? There's when the symptoms include fever, headache, weakness, and sweats, without all of that coming out, the rash, okay? That is called the prodrome phase. And then there's the rash phase, and there are different types of rashes. So the important thing is to know that the rash, I think, is the identifier, and that is the later stage of the disease. And you can see that these are the favorable spots of the rash, usually in the limbs and the genitals, okay? But you may have muscle X in the upper part of the leg, the femorals and so on. And you may have chills and the rest, which makes you feel, ill, including sore throat, which you can confuse for any streptococcal sore throat. But when you begin to see lymphadenopathy, especially when the inguinal one, then you begin to something else. Now, the summary of it is that Mpox is an STD. This I think goes without saying. Next slide. I would like to almost conclude. These are the different types of the rashes. It's the same but different progression. From when it is small, becomes pus, vesicular, some fluid there, then pustular sometimes, then it may burst, and then you have, the scar. So you may miss it, but, this is not necessarily your rim, but that of clinicians. But it's good to just know, sometimes to link the lab to the picture. Next slide. So the Mpox pathway of clinical care includes the diagnostic testing which I wanted to now go into briefly, just briefly, because again, I'm not an expert, but I made some observations in that meeting that I thought I should share. Next slide. So the other important thing, of course, is that these are the, you know, the nature of the admission. The cumulative admissions are about, you know, over 50%, over 50%, and that is important in terms of how we screen. Maybe we are under screening, and most of them were discharged. Most of them were discharged, and the cumulative deaths are about 50. Next slide. Next slide. So the other important thing that I noted here is that these are the different laboratories. I may know some, I may not know some. But what was important here is the last column. The last column shows the positivity rate. And my question, which perhaps the experts here could discuss in the discussion, is this variation from 3% to 55%. Perhaps it's the, you know, the prevalence in these different places, but it could also be the screening strategy. How are we screening? So much so that at 57 or 55% we are under screening, and at 3% we are over screening. But remember, these are labs; these are not necessarily the clinics. But supposing it were a clinic, this would be very important decision point. You know, when you do the positivity rate in the lab, you tell your clinicians and your nurses at the front line, you may be over screening or you are under screening, and it has an impact on resources. Next slide. Let me say a few things about vaccination. It is available. This is one important thing. But the other important thing is it has you know, its efficacy is good, about 75%. The way it is administered in Uganda, that is the single dose, you know, different from 8%, which is administered with the you know, prime boost, you know, the booster dose. Now the real booster dose is not given in Uganda. It's really availability. It's really availability, and therefore the thinking now is one to even make it in a way that we spread, you know, we spread the risk and we pool the resources, you know, that principle of insurance, by dividing the vial, which has, I think, 5 mils or 0.5 mils. I need to be corrected, I think it's 5 mils, to 5 times, 0.5 mils. So you give 0.1, so that now the vial serves 5 people. So they fractionate the vaccination. Next slide. This is a very important slide in terms of vaccination. Over 100,000 doses have been given. But I think the vaccination could be, in terms of people, I need to get the correct figure. And these are the risk groups, you know, very typical of again, the HIV risk groups, you know, fisher folk, long distance drivers, and other key populations which, you know, we need to identify. And the target age group is really the reproductive age group. And, finally, and this is a personal experience, and it doesn't sometimes sound very, should I say, sexy. You know, when we were in the Ebola meetings with all these big groups in the National Task Force, you know, a lot of effort is put there. And then when we had reached the 55 days, this is the latest outbreak, 2022, you know, then the space to present malaria came about. And to me, who was an outsider, I realized that, you know, there were 55 deaths of Ebola. There could have been more, maybe 500. But when they started reporting the malaria deaths, then it became clear that, all right, we almost closed our health system for these outbreaks. But, you know, the ongoing, should I say, pandemics, they need even more attention, because the number of deaths were in hundreds and thousands every reported. But Ebola, when there's one case, we split it and say who might have brought it. The border came here and there. We even have an epimap. But the complacency around malaria as a big killer, by the way, is something we need to think about on how we structure. When we are too much into it as program managers, as directors, we get lost. and we forget that actually there are these usual killers, which are ongoing, should I say, epidemics. Thank you so much, Madam.
Thank you so much, Dr. Buku. I think we shall give you an applause of our hands and say thank you for the great detailed presentation. We really appreciate. And Dr. Buku, like I told you colleagues, is passionate about policy, our personal safety, like he said it in here. He has been very instrumental in guiding some policies and guidelines, and we're glad to have him part of this engagement. And we do not want to lose you in one way or the other in anything, but we shall always make sure you're part of our engagements, Dr. Buku, more so regarding policy. And I'm happy we have the Umlta leadership here as well. Eric is on the call here. We shall give him time and his team to have a word or two later as we get down to the tail end of the discussions. But I know Eric is also interested in some of these things like policies, and is our president for the Umlta alongside his leadership here. So colleagues, I'll give a heads up some people at the tail end as we're discussing. But allow me invite Dr. Sauda, and I want to thank again Dr. Ibuku for bringing out these very clearly. They are very passionate, very clear, thought through, that we need to always appreciate as we get into these responses. I mentioned about the frontline colleagues who sometimes follow different directives from different people and forget about their safety and go into some of these engagements. You've seen what it costs for one when you lose a life and how much compensation can bring forward for any of us. So I am looking at some of these cost benefits that do come with our engagements, but take a keen approach on we being safe as the most important thing. And he mentioned about malaria. Yes, that's a very key thing. And we have seen these silent killers in the country. Some colleagues here do run some of these programs. And the other bit that comes through for us to really take note is to always take good policy decisions when it comes to matters that require our engagement as laboratory leads. So we like to thank everyone for listening and also backing what he has said. I know the discussions will be good. Allow me to invite Dr. Sauda in this moment in time, so that she can take us through our presentation. Dr. Sauda, are you sharing, or you'd like me to share on my side?
Thank you, share. Thank you.
Okay. All right. Just a minute, colleagues. Let me end Dr. Buku's presentation. Then I share Dr. Sauda's presentation. So, Dr. Sauda, over to you.
Yes. Thank you so much, Mr. Morgan, Peter. I'm very delighted, like I said, to be here before the team of experts who are really just sharing knowledge about Empox, and specifically related to antimicrobial resistance. I think the area of focus will be bacterial infections. My colleague has really said a lot about the extended testing. As you proceed, so the area of focus will really be what are we doing about microbiology testing and subsequently detecting antimicrobial resistance. But just like the preamble my colleague gave, antimicrobial resistance, specifically antibiotic resistance, is as a result of bacterial superinfections. But what is very important for us to know is Mpox patients are not in isolation. They are prone to bacterial infections just like any other person, but then they even have an extra susceptibility to these infections because, one, many of them have comorbidities, but also the prolonged hospital stay and the fact that they have lesions which break the natural integrity of the skin poses extra risks. And the risks are in a continuum, and that will bring us to the laboratory tests. So we have a continuum because usually, apart from other infections that they can get, it is usually primarily coming from the wounds themselves that have become the lesions that usually break the skin barrier. So it's a continuum of presentation or signs and symptoms, starting from contamination, because these wounds, just like any open wound, might get contaminated with microorganisms. But because it is contamination, they will usually not multiply, but they will persist until suitable nutritive or physical conditions are available, and they will then evade the host immune defenses. So therefore, their presence are really transient, and wound healing is not delayed. Then we also have a set of colonization where these species successfully will grow and divide, but they will usually not cause tissue damage or initiate host wound infection. Then now we have the local infection, and this is commonly misunderstood. Many times people say they have sepsis, but in essence, the actual term is local wound infection. This is what is visualized as hypergranulation, bleeding, friable granulation, epithelial bridging and pocketing in the granular tissue. The wound breakdown, there is wound or delayed healing, there is pain, and this is either new or increasing pain. The wound healing is beyond the expected, and within about 14 days, we expect the wounds would have healed. But the moment you go beyond 3 weeks and there is delayed, this is what we call delayed wound healing. Then, of course, we shall have the local signs of infection, which include erythema, swelling, a purulent discharge, delayed healing. I've already said this. And then we have the malodor or the bad odor. Then from the local wound infection, we can have spreading infection, where we shall have extended induration, erythema, crepitus, wound breakdown.
Are you on is the presentation on your side? Just to be sure.
Yes, Morgan. Then ultimately we go into severe sepsis, and it is the sepsis which has the systemic involvement. And I'm giving this preamble because it will determine the samples that we collect and the management. So Morgan, proceed. Yes, so now in terms of the local tests, we have learning outcomes, which include what are the specimens we require. But remember the continuum as we are discussing this, the sample collection techniques, the techniques for inoculation, the identification and the biochemical tests, the setting of the antibiotic sensitivity or susceptibility testing, result interpretation and reporting. And then, of course, some precautions and why AMR stewardship is important in Empox. So, like I said, if the indication has gone if the continuum has gone as far as sepsis, then the specimen required is a blood culture. But if it is just at local wound infection, then we stop at the swab, that is the wound swab, or in good settings or situations where we have extensive tissue necrosis, then we can take whole tissue. So these are bottles, just a minute. Currently, we have 2 common platforms for culture bottles. We have the BD, which are the common bottles that you have all seen, and then we have bottles like this, which are for platforms like the bacterial, and both are present in regional referral and national referral, depending on the hospital where you are. We have one of the 2. And then the sterile or AMI swab are the common swabs that you know. Proceed. So the sample collection is very, very important. In fact, it determines a lot about the yield and the interpretation of the results. So first of all, we collect the samples in an aseptic manner. And by aseptic, I just want everyone to imagine they are either collecting CSF, because this is why usually we emphasize a lot of aseptic, or call it before a surgery. So the care you exhibit when you're doing a surgery is the same care we expect. And then we emphasize that we talk of a sample before antibiotic administration, because you do not want to interfere with the yield of the culture. Blood cultures, we encourage 2 sets from venipuncture, from different venipuncture sites. And of course, on top of the making sure you're doing it in an aseptic manner, we also encourage the swabbing of the top of the bottle to ensure that the bottle is also not, because when you remove that metallic cap, the rubber cap should also be swabbed with alcohol, and you leave it for ample time to allow the effect of alcohol to take. So the wound swab, on the other hand, you also use a sterile swab for wounds, and you also clean the wound surface with alcohol or cotton before collecting the sample. And we encourage to take a deep tissue as much as possible, and where the wound is really purulent and you're getting oozing pus or that serous liquid wound fluid, then you take that. If you can aspirate, the better. Then before you even document, it is very important that you make a detailed fill of the laboratory request form. We have a standard microbiology request form that is available and accessible to both private and government facilities. So then you label and document, of course, making sure that the tally the patient details on the laboratory request form. And then you, of course, put the patient ID, the history, the site of collection, clinical history. Don't just say wound sepsis or wound infection and then you send, but give a detailed history. And then document the antibiotic use prior to the sample collection in situations where you cannot control that, and transport promptly to the laboratory. Next. Then the detection methods, of course, we always start with, if it is a wound swab, then we start with a gram stain to determine whether these are gram positive or gram negative. However, when it is a blood culture, then we start with putting it in the automated blood culture machine, or we can use the manual, but really we are discouraging the use of manual because they're very tedious and have a high failure rate. So we encourage the automated, and these again are available in many, actually all our regional referral hospitals are now having automated or can have access to automated systems, and our national referrals and some few district hospitals. But where that is not possible, we are encouraging utilization of the hub system to the nearest facility. Then after that, for blood, then we can also do the gram stain, which we call the primary gram. Then we use the standard media, which is the blood agar, the maconke, and chocolate. Now these are the blood agar, usually call it the food for the bacteria. So you inoculate the bacteria from either the wound swab or the blood onto that media. You allow the bacteria to feed onto the media. You incubate it to give them the warmth that they desire, just like you would want to go into your blanket when it is a rainy day to get some warmth. And then they will grow, and that is when we are able to, and different media, the word blood, maconke, or chocolate shouldn't disturb you. They're just different media that have different nutrients that favor growth of these organisms. Then after this incubation, either in oxygen or without oxygen, in carbon dioxide, depending on the organism that we suspect. That is why it is important to tell us the site of the wound so that we know the organisms we expect, and then we incubate appropriately. Then you again do a second gram, which is a secondary gram, to identify and see whether the organisms, because sometimes you may have only one dominant organism on the first gram, and then the second gram will help us identify which organism. And then finally, we do the identification, which is either manual using biochemical tests. Different bacteria have different behaviors. Just call them like languages they listen to. So those are the biochemical tests. So when you put different biochemical tests, then you can be able to say if it reacted like this and like this and like this, it is Staphylococcus aureus. But better still, we could use automated methods. And again, the government of Uganda, together with these partners, have made a lot of efforts. And we have many of the regional referral hospitals having automated identification machines, which we call the VITEC, that can help shorten the process to about 2 days for identification, as opposed to the routine, which could take probably 5 or 4 days, depending on the growth characteristics. And then finally, we do the antimicrobial susceptibility testing. Now, there is a slide that Teba showed, where we are having media and then we are having round things which are antibiotic discs. So the bacteria clear the discs if they are susceptible. The discs have bacteria which will clear, have antibiotics which will clear the bacteria around them if they are susceptible, or they will not clear if they are resistant, and then we can get a final report. But again, we have automated platforms now in many of our hospitals to do this, and that is how we come up with a report that we provide to the clinician. Next slide. Okay, so this is just a pictorial. So as you have seen, you're seeing the pictures are showing you how we streaking is like trying to spread the bacteria on the slide. So from 1 to 2, A, B, C, D, we have gotten a loopful of either the pus or from the blood culture bottle that has been incubated. We spread, and then in the next picture, that is, we have area A where we have the heavy confluent of growth. Then B, area 2, sorry, we have the less dense. Area 3, we have the weak growth. And then in area 4, we have the discrete colonies. And those discrete colonies is what we pick and put either in the biochemical manual testing or on the automated testing. And then the pictures below are just showing the different media. The one that looks like chocolate is really chocolate. It has particular nutrients that favor some organisms, like Haemophilus. Then we have the blood agar, and then we have the maconche. And the maconche is usually very good for gram-negative organisms like E. coli. Proceed. Now, these are characteristics of elevation, is elevation, that is the EDP characteristics, the elevation, the texture, and the pigmentation. Now, on top of just looking at the growth on the plate, we also look at particular behaviors of these colonies, and they help us. So it is like a combination of different things, the way the clinician would come in and then look at the presentation of the patient and keeps getting all the characteristic signs and symptoms, and then says this patient has maybe Ebola in view of the above presentation. So even the bacteria, we follow the same order. We look at the examination on the gram, then we look at the plate, looking at the elevation, the description, the surface, and the pigmentation. So we have particular telltale signs. For example, you see mucoid colonies, and then you know maybe that it's a bacteria like Klebsiella. Then you look at maybe the pigmentation, which is very characteristic, for example, for Pseudomonas. And then we also look at the gram stain to, again, back it up. Then we use the different biochemical tests, for example, the catalase, the oxidase. So these are different biochemical tests that we use, and they help us in identifying. And then finally, we do the antibiotic susceptibility, and that is how we come up with the presentation. Now, in antibiotic susceptibility, it is very important that we also look at the standards. So the complexity keeps increasing. You start small, then you keep, those of you who did biology, remember on maconche. So you keep bringing out. Now, if those ones grow on maconche, what is the appearance of the colonies? Then so you keep getting narrower and narrower until you reach a final conclusion. Then you go to the susceptibility testing. Now, in the susceptibility testing, we follow a standard. Morgan, proceed. Oh, this is going to be a bit tricky. But anyways, let me first complete the issue of the susceptibility testing. So many times you ask us, why have I given you bacteria and I've told you this patient has been on, for example, nitrofurantoin, but then you've not set it, or the patient has been on maybe a particular drug, maybe Amoxiclav, and you've not set it. So we have a standard called the CLSI, the Clinical Laboratory Standards Institute of the CLSI is Clinical Laboratory Standards Institute, which gives us the different antimicrobials that are expected to treat or to be to work on different organisms, and it excludes those antimicrobials that are intrinsic or naturally or inborn errors of resistance. So those ones we do not bother to test. So that is how we come up with a list. Now, this is just trying to show you the complexity. So we began with the gram appearance. So yes, the gram appearance, so gram positive or gram negative. Then we look at, is it bacillus or coli in terms of shape? And this is usually in a microscope. Then we shall look at whether it is aerobic or anaerobic. Then we look, if it is aerobic and a bacilli, then we shall look at anaerobic, for example, Clostridia. Aerobic, then maybe Listeria, then the cocci. We have aerobic, which include the staph or the strep, and you can easily see these shapes in a microscope. And then you go on to look at different biochemical tests. And for the biochemical tests, this is something that is that they are very small, but what is important is some of the biochemical tests that we use include the utilization of lactose by the bacteria, and whether it utilizes it or not, there's a particular appearance. Then we have the oxidase, whether it's positive or negative, the citrate, the motility, indole production, urea, and then we look at the triple sugar ion behavior. So these are different biochemical tests that we look at, and then given just looking at this chart, for the microbiology laboratorians, you know how to look at this and say, okay, it is positive and negative and positive and motile. Then we can easily conclude that this is most likely E. coli or whichever organism you have according to that chart. Proceed. Then for susceptibility, yes, this is actually the picture that I wanted. Yes, thank you. This is the picture that I wanted. So we have the agar plate, and then we have the different discs. And the disc, as you have seen, we have the microbial, then we have the zone on inhibition, which is the white, and then the bacterial growth. So when you put the microbial disc, then you expect clearance. But if there is no clearance, then that means the organism is resistant, because ideally you expect to have a zone of inhibition or clearance, and it is this diameter that we measure and then come up with the, so the diameter of, and by diameter I mean the whole length, not the radius. So the diameter from one end to another with the antibiotic disc in the middle, you come from one end to another, you measure, and then that is what you put, and you look at you compare it with the standard, and then you say if it's, for example, 18, and then you say that is susceptible. If it is maybe 15, and maybe the standard says that is intermediate, and then we have resistant when maybe the clearance is probably less than 6, depending on the organism. So that is how we go about the testing. So here we can use a vernier caliper, or we can actually use a ruler. But there are other methods, like I said, like the automated, which is the Vitek. And then we also have other platforms like the BD Phoenix. But Vitek is very important because many of our regional referral hospitals now have it. Proceed. So what is very important, and this is very similar to what I started with, is identifying pathogenic organisms versus contamination based on the site and the clinical context. So like I said, the wound can be contaminated, but not necessarily having the local infection. And then we also have some bacteria that we really do not get worried, because they've not been known to cause actual wound infections, or even in blood they are not known to cause actual disease. But it is important that the clinical history is given, because in particular clinical scenarios, for example, we have the coagulase negative staphylococcus. Coagulase negative is because of the way they present when they are expected to do coagulation of blood. Of a particular, there's a particular we test for coagulase negative or positive organisms. So if you have coagulase negative bacteria, in some instances it is recognized as a true pathogen. For example, the premature babies, whereas in an adult immune competent with coagulase negative, we disregard that as a contaminant. So it is important that a detailed clinical history is provided for us to determine the context of whether this is a contaminant or an actual pathogen. Then we interpret the susceptibility profiles according to CLSI or UCAS. So this UCAS or CLSI is just whether America or UK. They are really similar, so we really don't have a problem, although in Uganda we generally follow the CLSI. Somebody will ask whether we have a national standard. No, we don't have a national standard, but the Ministry of Health accepted and adopted the CLSI, so it shouldn't be a problem. Then it divides the resistance into susceptible, intermediate, and resistant. And you use the standard reporting templates highlighting critical values and resistance findings. So critical values are depending on a sample and the organism. For example, just like we would say gram staining in CSF for particular organisms, like for example, Neisseria is a critical value. Or maybe if we say a positive blood culture with significant growth is a critical value. So these critical values are reported immediately even before finalizing the lab report. We report to the clinician because it is important to start care. So it is important that when you're requesting for microbiology test, you put the requesting clinician's name and contact to aid in this communication. And then, of course, depending on what the organisms identified is, we recommend either de-escalation, that is going to a lower level antimicrobial. For example, you can come from meropenem to say amoxiclav, or you can escalate depending on, for example, you could come from piperacillin tazobactam to say cefepime, or you can just remain where you have been. You might have been giving the patient gentamicin, and then the results say continue. So we have critical results or particular organisms that are very important, for example. And here we have an example of cefotaxime disc. Then we have amoxicillin, clavulanic acid. And we are supposed to, this is just supposed to show us how we look at some of the antimicrobial susceptibility and the critical results. And for example, we could look at methicillin. There are particular multi-drug resistant organisms that are of interest that have implications on the patient care, but also even on the infection prevention and control measures. Some of them include, for example, the methicillin resistant Staph aureus, which is looked at using either the oxacillin if you're using the disc, or you can use the cefotaxime if you're using the disc, or oxacillin if you're using the MICs, which are usually either manually done or machine. Then we also have sample organisms and their resistance. For example, you might say that, for example, for clindamycin, anything above 21 is sensitive and anything below 14 is resistant. This is just giving you a picture. And then we also have other MDROs like the extended spectrum beta lactamases, where you're looking at the synergy or it's called the champagne cork image, where you look at that I don't know if you're seeing that image between the two. And then you come up with conclusions that you have these particular organisms, and this would usually be put on the request, on the results. So they will put maybe you have Klebsiella pneumonia, and then they'll put ESBL. So ESBL is extended spectrum beta-lactamases. And of course, this has implications because then you're not expected to give particular classes of drugs, which are largely the beta-lactams antibiotics. Proceed. Yes, so in terms of diagnostic stewardship for Mpox, especially for antimicrobial resistance, Mpox can lead to complications such as secondary bacterial infections and sepsis. And early identification and appropriate antimicrobial therapy are key in improving patient outcomes. Sepsis is life-threatening. So, and you've had scenarios where we've even lost patients who probably would have been saved. So that session will look at, this session now, the next few slides will look at the diagnostic stewardship for bacterial infections, the appropriate use of diagnostic tests to guide effective treatment decisions, and it has 3 R's. We have the right test, the right patient, and the right timing. And by the right test, of course, we mean the correct indication. And the right timing is usually or always before antibiotic institution, and then in particular cases, the timing also differs. And then the right indication the right test is ordering the right culture. Don't order for blood culture when you're suspecting a local wound infection. It is an intimate cousin to antimicrobial stewardship, and because antimicrobial stewardship promotes optimal selection, dosing, and duration of antibiotics to improve outcomes and combat antimicrobial resistance, there is no way you can select and dose the right antimicrobials without having the right diagnostics. So the patient is evaluated for symptoms, diagnostic testing is performed, and then the empirical antibiotics being prescribed comes in after you have done the test, and then you modify the antibiotic test that is in stewardship. So we look at ordering, the clinical context and risk factors, and the clinical bias. So the test ordering should be looking at what I normally call the triad. So the diagnosis in terms of the anatomy, so where is the problem, then you will know the right test to order. Then where is the diagnosis in terms of pathology, so what exactly is this? So is this really a septic infected lesion, or it is just a lesion because of maybe syphilis or any other lesion, and you're not suspecting the common bacteria? And then we also look at the diagnosis in terms of etiology. So what are you suspecting given the clinical picture? And that is when you order the right test. Then the specimen collection and processing, you want to avoid contamination, collect the adequate sample and the right sample type. And then you look at the volume, because you want to ensure that you reach the laboratory threshold. And this is very important, especially for blood culture. We usually request for 8 to 10 mils in adults in our common bottles. And this is different for children. We expect 1 to 3 mils. Then the reporting, this helps in reporting whether it's a true infection versus contamination or colonization. And this comes from the combined effort between the clinician and the laboratorian. And it's supposed to be a discussion. When you get the results, you're supposed to discuss with the clinical care team to make sure you give the right guidance of the test interpretation. And then finally, you optimize empirical antibiotics, and then antibiotic post-prescription review to find out if your antibiotics are really working. And this is how the antimicrobial stewardship comes in. So it's really a continuum, starting with the diagnostic stewardship and moving up to the antimicrobial stewardship. And in our facilities, this is all under the antimicrobial stewardship subcommittee, both diagnostic and microbial stewardship. Proceed. So it really emphasizes timely and appropriate testing, and this is very important. A timely test, especially in situations of sepsis, is very, very important, because when a patient is getting septic, we do not have a lot of time to dilly-dally. So as soon as you suspect sepsis, and of course suspecting sepsis comes from looking at the clinical presentation, the current surviving sepsis guidelines recommend the QSOFA, where we are looking at the quick sepsis organ dysfunction matrix, and then you score and you determine whether the patient is really septic. But even if it is local wound infection, you really want to ensure that you're getting the patient the right diagnosis, and ensuring that all samples are collected before initiating antimicrobial therapy to preserve diagnostic yield. So the right sample, the right time, following the right protocol, whether it is wound swab or blood and other relevant specimen, and molecular testing. You find that if it is culture, it's a different sample, but molecular also requires a different sample. And we discourage the overuse of cultures. For example, when you have local wound infection and then you order for blood culture, that means your diagnostic stewardship has not been done well. You've not followed the etiology, the triad of what is the diagnosis in terms of anatomy, pathology, and etiology. So this is just repeating what we have just said, but in a picture or in a pictorial. And I want to emphasize the decision support nudges. The decision support nudges are really just like maybe reflection points. So you are looking at this patient and you're saying, I have ordered for urine culture. And then you're saying, okay, hold on, what is in this patient that shows that this patient has a urinary tract infection? If you don't have it, please do not order for the culture. So similarly, what is in this patient that makes you suspect a bloodstream infection? Bloodstream infections have their presentation. If you do not have it, please do not order for that. But if the patient has a bloodstream infection, then order for it. And then also, every time you see a patient who has a bloodstream infection, on top of ordering the blood culture, also think back and see what could have led this. Where is the primary focus of infection to reach the blood? How did this patient's blood get this bacteria? So you want to think, where is the primary focus? Could it be the lesion? Could it be the urine? Could it be the respiratory? So that you have a full picture of the patient. Then you, of course, you do the test processing and then you report. And also this emphasizes the turnaround time. You do not want to report the result when the patient has already gone. So we encourage also the laboratorians to ensure that we work within the acceptable turnaround time and communicate effectively to the clinical team whenever you have any delays, and you also give them preliminary results. Proceed. So yes, this is the picture that I love most. So we are saying the broad empirical therapy will come in before the diagnostic testing, and then the effective targeted therapy comes in after the diagnostics. So as you see this, it is a square, and a square, all sides are equal. And because all sides are equal, that means the diagnostic stewardship is as important as the antimicrobial stewardship. So we do not want to disassociate the two. They are all as important. So what does this mean? The clinician, the laboratorian, the pharmacist, the nurse are all important. And I usually want to put on one side the diagnostic person, the laboratorian. On the upper side, I want to put the nurse. The lower side, I want to put the clinician, the pharmacist. And then down here where we have microbiology laboratory, I want to put the doctor or the clinician. And just to show that as you look at all these people, they are all important to ensure that we have the patient well managed. And in the middle, you're seeing the healthcare provider, but you can even remove the healthcare provider and put a well managed patient, because this is a concerted effort, and it all starts from having the right test, the right patient, the right time, but after giving the empirical therapy. And why this is also important is even subsequent accumulation of results will help us look at the antibiogram, which is the list of drugs and the organisms and the drugs they respond to, so that we can be able to decide the effective empirical therapy, so that even before we get the culture results, we have at least have had empirical therapies like guessing what could work. So we want to make an intelligent guess by utilizing the laboratory that is having enough samples that have been analyzed, and then we can look at the resistance trends. So this is, if you must forget anything, please don't forget this slide. Yes, proceed, Morgan. So we are coming to the end, identifying the organism. I think this we have already talked about, the interpreting the results, the AMR patterns, flagging the mild drug resistant and extensively drug resistant or pan drug resistant, and then the alerting the clinicians in terms of methicillin resistance. Methicillin resistance has a high potential for spread between patients. That is why we overemphasize it. Extended spectrum, the same thing, and then the CRE, which is the carbapenem resistant enterobacterias. Enterobacterias are just organisms like Klebsiella and E. coli. So we want to report because we want, one, these patients deserve to be isolated, and then we do what we call barrier nursing or contact precautions to ensure that we do not get this drug-resistant bacteria from one patient to another, because they are very hard to treat. Just that antimicrobial resistance is a silent pandemic, but trust me, it can be worse than even Ebola if you have an outbreak of these bugs, because the choices of antimicrobials are very few. Sometimes there's even none. So the reporting is standard, and the government of Uganda through the department has standard reporting formats, standard microbiology request forms, and then also have a guidance on how we do this, and we have quality checks to ensure that the laboratories conform to these standards. Proceed. So then we also store and freeze isolates, and we report to the national AMR surveillance. Of course, the isolate storage is a requirement for AMR surveillance, because then we want to look at whether we are having new resistance that is coming up or it is the old, and also look at relatedness between isolates. So do we have the same resistance in, for example, Karamoja as we have in Kampala? But also, as a requirement for AMR surveillance, we are supposed to report to the global resistance surveillance platform. So we have to have this stored and retested. Then we make monthly summaries, and these summaries should not just be for example, Empox sites or national, but they should be utilized by the whole facility to develop antibiograms, and then have empirical treatment protocols, and then participate in data sharing and communities of practice like the telementoring sessions that we normally have. And then, of course, give feedback to AMR committees. Next slide. Yes, so before, of course, all this is done with references. They are not, they're neither my words well thought of, but customized to the Ugandan context. So I want to finally request or inform everyone on this call that the government of Uganda has been able to ensure that there are supplies for diagnostic testing of blood stream infections, specifically blood culture bottles. And should anyone fall short of blood culture bottles, at least between now and December, kindly raise your concern to me or anyone in the department. But particularly if you raise it to me, because the department or Mr. Mugera, the department, or Dr. Najuka, those are the three people, Mr. Mugera, Dr. Najuka, or myself, the department has a plan for redistribution, but then we can also see if there are any extra needs, then we can be able to support different facilities, especially with blood culture. And then finally, I know we are all here in different capacities, but in a special way to the prescribers, you hold the key to AMR support because you decide on whether to utilize the laboratory or not. So we are currently encouraging and acknowledging the prescriber as the AMR champion. So the campaign goes, my prescriber is my AMR champion. So prescribers kindly utilize the laboratory so that we can be able to curb this problem of antimicrobial resistance, especially when it even comes to patients like Mpox patients who are in isolation and they are prone to these resistant organisms. Thank you so much. Over to you, Chair, for any questions.
Yes.
I'll be responding.
Thank you so much, Dr. Sauda. She's one of the champions for diagnostic stewardship at AMR. And I think her last statements are very pertinent to increase the demand for blood culture utilization, for those patients who have spiking fevers, for those patients who are deemed thinking that they have bloodstream infections and they have been screened. Please make sure you utilize the blood culture space to ensure that we have testing done. A lot of capacity has been put in these regional referral hospitals to support microbiology on-site capacity, as well as the CAP-accredited lab that is at CPHL, the first public health CAP-accredited lab that is also providing the other extended platform for testing through their technical teams. But by and large, it's just to say, Dr. Oza, thank you so much for the presentation. It was more detailed. And I want to inform colleagues on this call is that for most of the public health diseases we have, most of them end up having a sepsis presentation at some point in time. And this is the reason why we want to now make sure that for all these cases that present with a sepsis tendency, should make sure that we utilize the microbiology services that are available, and also the laboratory testing platforms that are already in existence, like Andrew Teba mentioned, and also taking care of ourselves as we work, like Dr. Buku mentioned. With us here, we have our Commissioner, Dr. Nabada, has joined us on this call. And before she comes in, allow me to say a few remarks here to thank some colleagues who have been very important in setting up this. One, I think, is the former Vice President of Umlta, Gad Mbera, who ignited all this CPD program. We really appreciate that from you. I also want to thank Doreen Nabasiri, our administrator on the laboratory pillar, who always convenes and makes sure we can pass on this information. I look at colleagues like Ochen Francis, that is from Africa CDC, Gordon Mpamize is a project manager, programs manager at JCRC. Then also take note of Professor Kilian, Benson Ouma from JCRC, and the Umlta leadership that is on this call. We really appreciate that you've given us the platform as the laboratory pillar to make this presentation to our colleagues. But before I say this and give room to our commissioner who is on the road from Fort Portal, allow me to request Eric Okek on this call, the president, to have a word or two. I know we have gone past the top of the hour. And then Eric, I think I'll give room to you to invite Dr. Susan Nabada to give her parting remarks. Thank you. Eric.
Yes, thank you so much, Morgan, and all the presenters, Dr. Ekwaro Buku, my brother, colleagues. Is contesting for Member of Parliament for Oyam South, and this is a call to action. Let us support our brother. At an appropriate time, we are going to have a separate meeting with him and the selected individuals from the lab fraternity. See how we can drum up support for him, but also how we can chip in our trade-off as a profession when he becomes a Member of Parliament. We should have very specific demands from his side as we also support his candidature. But that is for another discussion. Then Dr. Sauda, thank you so much. I knew we would go very far. Then my good friend Andrew Teba, thank you. To the rest of us, before I invite Dr. Susan, I want us to appreciate the role that the association is conducting We know that putting up or patching up this together is not something easy, but as we speak, we are grossly few in numbers. We are only 300 and I think about 450 registered members of the association out of about 22,000 potential members. So now that we're benefiting from the work of the current administration of Umlta, I implore and encourage all of us to register with the association. Yusuf and the secretariat will share the registration link and how you can make the small payment. It's very important that we generate a required number so that we can do the advocacy and lobbying. Also, when we're meeting other stakeholders like the commissioner and the team from JCRC, IDI, we have the bargaining power when we have the numbers. So you support us so that we can sustain such initiatives like this series here. I have my other question. I think I will ask. These are technical question to presentation, but I will not ask now. For now, I am so honored to invite the Commissioner, National Health Laboratory Services, Dr. Susan Nawada, to say hello to the esteemed members of the Medical Laboratory Fraternity. Dr. Susan, you are welcome. Colleagues, let's put some flowers as we welcome Dr. Susan to make her remarks.
Thank you so much, President. Thank you so much, Morgan, Umlta team that has put together this webinar, which is very timely. Sorry, I was supposed to be with you from the beginning, but I had to be in Fort Portal where we have registered another milestone where we've got a state-of-the-art BSL-2 lab in Fort Portal Regional Referral Hospitals, 2-storied, officially commissioned by the PS and the Minister of State for Health. So I had to be there. So I want to thank the ministry and the leadership for making sure they look for resources to support us. I don't know if you're hearing me. I'm on the road, but allow me also to continue thanking you for the great work you are doing as the lab professionals, because we know you are at the forefront of all our health initiatives. You are at the forefront of the public health surveillance we do, the diagnostics, the response we give in this phase of the infectious threats that we have. More so to speak to the webinar today that is looking at enhanced testing for Empox clinical care, and more so specifically looking at AMR resistance, AMR state. As said, I won't be big. Really at the response. You've had that there's need to rest, but even after we've confirmed, we've noted that there's creep. If it increase of the infection, and for those who are in our Empox in the they get with so we were not up to speed to be able to manage and handle it. So we felt like we needed to combat this big pandemic that is coming on board. I want to thank you for your presentation to take us through on how we can combat the sepsis in Empox, but beyond that, even letting us know about the current status and the capacity that we have at the ministry and in our different networks. Sensitivity. We cannot combat the sepsis that we are talking about if we haven't built capacity. So we want to thank the Ministry of Health for continuously building the microbiology capacity in the regional hospitals, national hospitals, and as we speak, we have some district hospitals and some health center force. We are doing this because we know we want to expand the diagnostic testing capacities to support the sepsis that these patients tend to get, but not only for Mpox, but also for the other illness. So, we've expanded. We are able, regional hospitals, most of them have come up with antibiograms to guide. So kindly, if we have clinicians here, use the lab. We need that demand created so that we are able to serve you, to be able to respond to your patients right. But also, we have managed in terms of Mpox testing. You've had Teba as was presenting, the issue is more around the centralized testing. But as we stand now, because we want to increase access and reduce the turnaround time, we want to decentralize Mpox testing. And as I think as we speak, we've managed to get some resources and reagents to be able to decentralize Mpox testing also to the regional referral hospitals. So you are at the center of all this. The trainings will take place so that you can support. As we decentralized COVID, some of these public health emergencies and threats, we want to start decentralizing them because we've built capacity at the regional level. So you are very, very critical and crucial in this fight against Mpox and against the AMR that we see marching up in Mpox to patients. And we believe with continuous information, with continuous capacity building, we'll be able to combat this threat that had come in. We shall continue and training as we are doing this. We shall continue the quality assurance to make sure that what is generated is from the right sample, that is taken off at the right time so that it receives the right treatment, but also make sure that we share the data so that we are able to make timely decisions and reporting in real time. So I know we've learned a lot in this webinar. A lot has been said, and I believe that we are going to use this to continue managing our patients right. Clinicians, please use the labs. The labs are available. They offer quality services. They have competent and skilled people, and we've managed to try and equip them. Kindly use us so that we can be able to give you the best to manage your patients. But thank you so much, Umlta. Thank you so much, IDI, for the support, and all the development partners that have supported the journey of making us where we are in terms of AMR capacities. Thank you. And with those few remarks, I hand over back to the chair. I hope I didn't break off as I was talking. Thank you, and Morgan, over to you.
Thank you, Dr. Susan. And colleagues, I want to thank Dr. Susan for gracing this engagement that you have had, the words and the direction you've given us towards how we are supposed to improve the public health concerns or events. We take this in deep heart and ensure we can prevail in everything we do. With all this said, colleagues, before you break off, allow me, I just want to give my parting remarks and thank Baylor Uganda that has been very passionate in supporting this development of these materials. Actually, they did the first stage of ensuring that we could see how we could introduce AMR surveillance alongside Ministry of Health into management of these cases. I want to thank the public health leadership program at Ministry of Health, the UNIHP program that has set up strong laboratory personnel who have supported the development of these materials. I also want to thank WHO, JAPEGO, CDC, IDI, UVRI for also supporting, and also the Ministry of Health that anchors CPHL and all the other testing reference labs, that is the Central Emergency and Surveillance Lab, NHLDS, the Genomics Lab, and as well as the National Microbiology Lab. I want to thank you all for listening to us. It's unfortunate we may not take on questions today, but the presentations will be shared for everyone to look through, and maybe in the other review of the remarks that have been made and the comments, we may answer them in our next subsequent presentations coming forward. So I want to thank you and wish you all a good day, and thank you for listening to us. Let's put this to action so that we can help patients and improve their lives. And thank you, Commissioner, for gracing this meeting. So otherwise, I want to thank you all and for being part of this. Let God bless you. Let's catch up again next time. Bye for now.